Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise, and we meet here every Saturday at 9 a.m. Central Time, and we don't miss a single one. This is our first episode of our second year starting, so great to that. Hey, if you're watching us on YouTube, LinkedIn, or Facebook Live, welcome to the show. For those of you that are on YouTube and you haven't subscribed, go ahead and subscribe. If this is your first time catching our show at UroNurse, be sure to go and check out our website at uronurse.com. It's the best place to go to learn more about the show. Also, the very best place to watch all of our past episodes. All 52 of those past episodes from last year are available. Also, we told you about a new feature last week called UroNurse Plus. It's a new section of the website. Had so much material that I wanted to give it its own site. And that's where you can go and listen to all of our podcasts on audio only in your car. So anywhere you want any of your great products here like Apple, Spotify, Amazon, Google, any of those you have, subscribe and you'll get the shows automatically loaded every week, and all past 52 are available. And those of you that are watching and you want to talk to us, comment box, no matter how you're watching, go ahead and put in your comments. We're glad to see those. I did put something out there. Just let us know where you're coming from. It's always good to find out where people are watching us from. This week's a little change. We're going to do what I'm calling our skills labs. I think these are aimed more towards new nursing, although there's probably good tips for all of us. Our MAs and RNs that are new to urology. So I'm going to talk about my teaching intermittent catheterization tips, and that's what we're going to go into. So let's go ahead and bring in our great group of experts right now. Hey, welcome, everybody.
Good morning.
Good morning.
All right. I'm going to go ahead and let you guys do your introductions and favorite stories. I'm going to bring Lori over here and go ahead and let us know something about you and a favorite story.
Good morning. My name is Lori Atkinson, and I'm a certified registered urology nurse. I have been in urology for 25 years, and I currently work for Northwestern at Delnor and CDH Hospital in Winfield and Geneva, Illinois. So I have a couple of things. So this one's a quick one, but yesterday we were prepping charts for Monday. That's what we do just to make sure we have everything we need for that patient that day. And we came across an appointment type, and this patient booked his appointment through my chart. And it was, I have morning erections. And he's 30 years old. And I don't know what we're getting ourselves into, but I can't wait till Monday to find out what that's all about. Also, I'm a big team builder. I love to have fun with my team. And so today we are actually going roller skating. And so,
wow.
Yeah, so it's not technically a work event because we don't want everybody on workman's comp on Monday, but we have a lot of fun. So hopefully I might have some pictures for you guys next week.
Oh, that's great. All right. And John, coming remote, a whole new place.
Yes, coming to you live here in Tucson, Arizona. Normally, I'm in Gilbert, Arizona as a private practice urologist. And like Vic, what I'm doing is paying it forward by sharing what little I know in urology after 20 years so that we can benefit everyone. To that end, I created a Facebook group called the Thriving Urology Practice Facebook group, where we have about 2,300 US-based urology folks joining us and collaborating. And as they say, rising tide lifts all ships. The story that I have today is probably something that you've never heard. I had just completed a TURP procedure in the operating room, and my surgical tech was relatively new to urology, but she's been in the OR in the surgery center OR for several months at this particular surgery center, and I've worked with her numerous times. Nicest lady. At the end of the case, normally I connect the inflow to a three-way catheter. So for those of you who are not familiar, the three-way catheter has an outflow port, which you're all familiar with, the big port right in the middle, and a balloon port where you inflate the balloon, and then a third port, that's where you put in the irrigation. When I at the end of the case, I inserted the catheter, so this port was already connected. And I figured there's only one inlet. I could just let her connect the inflow port. So everything got undraped. I went to talk to the family, dictate, write the note, post-op orders, etc. Before I walked out to the lobby, the circulating nurse came to me and said, "Dr. Lin, I tried everything I could, but I could not get the CBI to work." So I thought, okay, that's strange because everything was flowing beautifully. I walked to the bedside and started from the top. The bag, it was connected properly. It was plugged all the way in. The tubing was looking good, not kinked. The roller thing was open, so that was not clamped. And then I finally get to the catheter. She had connected the inflow port to the balloon port. The inflow tubing from the irrigation to the balloon port, and plugged the inflow port of the three-way catheter. Now, granted, the urine that was coming out, even without the irrigation, was nearly completely clear, thankfully. But that was my story. So why am I telling you this? First of all, you can't assume that everyone knows what you want them to do. In the operating room, you have to be explicit. And what ended up happening is the nursing staff got all upset about it, and I thought it was just funny. And I talked to the surgical tech. We had a good laugh. And that's the thing. You don't want to get mad at somebody for doing something like that. You want to make it a learning experience so that we can all improve the next time. Back to you, Vic.
Yeah, that's a great story. I tell you, I've seen it myself. Where when I was making rounds, and the irrigation won't work. Yeah, it doesn't work very well plugged into that port. So it does happen. Hey, I don't have a story this week because you guys sent me a story. So I'm going to read this story. Thanks from Jean Ann Dahl, who sent this from Albany Medical Center. I've been a nurse practitioner for 35 years, specializing in urogyne for the past 21 years. It's been a rewarding career with countless stories. It has been an honor to serve this underserved population of women. Recently, I treated a 78-year-old woman with OAB with PTNS, percutaneous tibial nerve stimulator, for those that don't understand the lingo, after behavioral and pharmacological interventions proved ineffective. She described the treatment as life-changing. Once using 4 to 6 incontinence pads per day and having to know where every bathroom was, she is now back to walking 1 to 2 miles a day without a pad. She's out socializing with joy and confidence. Helping women with urologic health issues never gets old. And what a great story. I think that we all have had those heart-touching moments. So, hey, if you guys have other stories and you want to share those, we're always glad to talk about your stories as well as our own. So great story. Now, I am going to tell some stories, but since I'm the presenter today, I've got a lot of stories built into this presentation. So with that, I'm going to go ahead and bring in our presentation. There we go. All right. So today I decided to do some what I call skills labs. This is aimed highly at the, as I said, the new people in urology, but I think there's some tips and tricks that everybody can learn. So I'm going to talk a little bit about my teaching tips for intermittent catheterization. Been involved in urology forever, 40 years. And one of the greatest, I think, things that I've been able to do is teach people how to catheterize and get rid of that Foley catheter when they're stuck with long-term drainage situations that are not correctable surgically. So let's go ahead and figure out which button to push. Here we go. So we know that it's really important to empty your bladder. Without it, we're going to run into all sorts of problems. It's simply urinary tract infections, urosepsis, kidney damage. I had a patient last week who I was doing an ultrasound, and I could see the TUR defect in his prostate. So I said, "Hey, did you have prostate surgery?" Younger guy too. And he said, "Oh yeah." He says, "Wow, what a thing that was." He says, "I was completely in retention. And they even found out I was in renal failure." So sometimes this can sneak up on people and they just compensate for it and don't realize that they're, getting worse and worse. And he actually had renal failure. Now, fortunately, he recovered after this procedure, was able to urinate, everything's working. But it just is a reminder, how important that we assess patients for urinary retention, because it's important to empty that bladder. Now, we know historically the treatment for bladder dysfunction has been a Foley catheter. Somebody comes in, they can't urinate, we put a catheter in and send them home. And then we try some treatment down the line, whether it's medical, surgical, whatever. We know that patients also treat their own incontinence when they start getting problems like overflow. They just start wearing diapers, thinking I can't control my urine and not realizing it could be retention. And even condom catheters are available, so they can get those. So people are pretty ingenious about how they can treat their own problems. Now, one of the problems is long-term Foley catheter is not a good solution. We know if you wear a catheter, there's going to be an odor. Most of us in the office that have been around for a while, I always tell them, if you want to know if somebody has a catheter, look for the guy who's wearing way too much Old Spice, because that's what they'll do, is they'll wear too much perfume, too much aftershave to try to cover up that smell. And the big thing is, when you're the one who has the odor, you don't notice it. I remember one day I had a little too much aftershave, and what do you do with it when you pour it in your hand? You just put it on. Went to work. I get home. My wife goes, "Wow, you had that much aftershave on?" I go, "I didn't even notice it." And that's what happens. Your own nose doesn't pick up odors that are consistent for a long period of time. So I didn't know that I smelled like I overdid it, but she assured me I did. And how do you politely tell somebody, hey, you kind of smell? So it's socially not all that acceptable. And we all know that it can really cause a lot of problems in households when that odor starts to build up. And I ask my audience, is this what you would consider quality of life? Running around with a Foley bag tied to your leg, a smelly bag sometimes. So I would say absolutely not. It's not a quality of life. So it's a quality of life issue to me. And so that's why I say intermittent catheterization. Why not you? A lot of patients will say, I'm not, I don't have any skills for that. I'm not in the medical stuff. And I'm like, no, you don't understand. This is a better solution. And it's just try to catch a good time to teach them. And a lot of times you'll be surprised how successful you can be. The other problem is when we have a long-term catheter, there's lots of complications. We know that. So some of those complications, we look in with a scope after somebody's been wearing a catheter, and that's what their urethra looks like. It's all red and inflamed. So we know we're causing inflammation. And do these get infected? It's not a question of will it, it's when it. They will all become infected over the course of about 10 to 20 days. They're all going to get an infection. No matter how good you do with not breaking the catheter, it's an open source for bacteria to climb in. We all have had these calls. Hey, I've got blood in my bag. Now what do I do? So, those calls are never fun for the patient. I think those of us that have been in urology for a while have all seen this. It's terrible. You hate to see it. But patients that have had long-term Foley catheters that have actually caused erosion right through the urethra, all the way to the scrotum, pretty much a non-correctable situation. Long-term catheters have been known to cause squamous cell carcinoma of the bladder. And episode 10, Todd Thompson did a great autopsy of a catheter showing what they look like when they block up, how much stone formation forms in those. I recommend checking out episode 10 if you didn't see it, because it's a great one. You can even listen to it on audio if you want. Now, I'm going to take a little different approach than Todd did. I'm going to get an electron microscope. I found a study where they looked at that super smooth, how the companies like to market that they're so smooth and everything. Well, this is what it looks like under electron microscope. Not so actually smooth. And I'll admit, if to the naked eye, they look really smooth, but they're not. There are little crevices, and as they go in there even under higher magnification, you can see some of those crevices are, for a bacteria, that's a hiding ground. That's a little cave. And so that's what they did. They inoculated the catheter to see what would happen. And what we can see is that within 2 hours, cells can, bacterial cells can be seen trapped in those little crevices. They find their way in there. They're not getting washed out. They find a spot to hang on. After 4 hours, microcolonies have formed on these. So once there's a bacteria there, hey, come on, buddies, the pool's fine. Join us. And after 6 hours, they start to form what they call microcrystalline material. basically the bacteria is trying to protect itself so that it's not going to get flushed away with this. Or bacteria can't be killed by antibiotics. They're hidden by enough extensive biofilm. It'll keep antibiotics from getting to them. So after 20 hours, we get an extensive form of this crystal. And this is the stuff that causes blockage. Now, this happened in 20 hours. We put a catheter in, send somebody home who's going to had a blocked catheter to start with. What do you think is going to happen? He's going to be back with another blocked catheter. So episode 10, Todd has some good options for how you can prevent this, but we know it's going to happen. Now, I think the best thing is to get rid of the catheter. Now, anytime we put a catheter into a man or a woman, we are making a judgment call. We're basically saying that you're not sexual, because I don't know of too many couples that continue to have sex when they're wearing a Foley catheter. And the truth is, older people are having more sex than ever, and that's based on studies that have shown rising rates in chlamydia and syphilis in the elderly population. There's a reason. They're getting it from having sex, so it happens. You know, and of course, that little blue pill had a lot to do with increasing that, because now we can Viva Viagra and living the Vitra Loco. The World Health Organization, the WHO, in 2002 actually put this statement out: avoid an indwelling catheter if possible. If assisted bladder drainage is necessary, clean intermittent urinary catheterization should be used. I don't like to read slides. I know you can probably read it faster, but I think the message is clear. We should be encouraging intermittent cath. So we need a superhero. You need you to be the superhero. You need to get out there and preach to the people. Now, I'm going to go through some of my teaching strategies. Hopefully these are useful for you. But I think it's always important to, have a positive attitude with the patient. This is something you can do. Let them know you're an expert. You've taught people before that this is going to be a good thing for them. And make sure they're ready to try. Some people will say, no, I can't do it. Okay, so next catheter change, offer it again. You get the right moment, you'll be able to be successful. Now, here's one of my big pet peeves. How many times have And I love our catheter salespeople. They come in with all these samples. It's great to have them to give to the patients to get them started. But I've had a few come in with this bag of catheters, loaded with catheters, and they say, what you do is you just give this to the patient, send them home with the instructions, and tell them to let you know which catheter was the easiest for them to use, and we'll get it. We'll put the order through. No, that's not the way to do it. That's the patients don't know. That's going to overwhelm them. They don't know what catheter to use. If you look in the bag, I can tell you the way reimbursement for catheters, they're all pretty much reimbursed at the same price. It's not the brand names get paid more than the less brand names. So trust me, the ones that are in that bag are probably not always the best brands. Sometimes that's fine. Sometimes it's not. But you, my audience, are the experts, or will be the experts. You're the ones that should make that choice. You need to tell the patient what to try. You need to show them. You need to see what works. And it's all about assessment. It's simple as that. We need to do a basic assessment of the patient. We need to do an assessment of the technique and what catheter we think is going to work best. And sometimes we try one and try another. But it's based on our experience, not just a bag full of fun. Now, we know that this guy, who's kind of a little less able and not as easily to get around, might need a different catheter than somebody who's the same age but is in much better shape. So we want to make our assessment based on the patient, not so much their age but their condition. I always say hand is probably the most important thing to keep in mind, because the hand will why did I go to that screen? There we go. The hand will tell you a lot about their dexterity. Can they touch each of their fingers? Are they loaded with arthritis? Do they have good grip strength? Because if they don't, then you're probably going to have a different choice of catheter than you would if they did. So body size can matter, especially when it comes to teaching females catheterization. If you've got somebody who's a plus size versus somebody who's not, you may want to use a longer catheter. Now, fortunately, most of the big companies have made different size female catheters now, longer ones and normal size, normal size ones. I've even gone and used some male catheters for some females. But, again, you're the expert. Look at the patient, try to figure out what's going to work out best for them. Now, there's two types of intermittent catheters out there, hydrophilic and uncoated. So the ones that have a coating and the ones that don't. I got to tell you, my go-to catheter most of my career was the uncoated catheter. I just liked it. I could tell you the one I used all the time. It was a 114 Coloplast, 114. It was a straight cath. It was 14 French, and it was soft. That was the 114s were the soft. I liked the softer catheter myself for most patients, and had a lot of success teaching with that. My big thing against the coated ones was I think sometimes they could be too slippery, and it's probably the case sometimes, but not always. And I will admit I have changed that strategy a bit. A salesperson I'd known from a previous company went to work for WellSpec, the company that makes Lofric, and guy I really kind of liked. He was a pretty, honest guy. Wasn't just out selling. He said, there's something to these pre-lubricated catheters. He says, a lot of our studies have shown that because they're so slippery, they're less irritating to the urethra. They're easier on patients. He said, I really think you should give it a try. So I said, fine, give me some of these catheters. The next guy I see, I'm going to go ahead and I'll give it a try with them. Well, I have to tell you, I was impressed. It did go well. Now, do I think everybody should be on a coated catheter? No. Sometimes patients that have, trouble with their grip, the slippery catheter is too slippery. So again, this is assessment. Decide what you think is going to be the best to use for the patient, and don't just go by because it's the better product. I will say some of these coated catheters are coming out with crazy innovations, and I've got a few samples I'm going to share with you shortly. But they are really good catheters because suddenly there's a lot of money in catheters. So they put a lot of research into how can they be better than their competitors. And we've had two companies, Hollister and WellSpec, which is the Lofric people, that were actually on the show talking about their catheters. So if you want to learn more about these branded catheters, go back and look at some of those episodes, because you'll be surprised at some of the information there. Now, the other thing that's different about catheters, especially for males, only for males, is coude versus straight. Coude is a curved tip. The reason you would use a curved tip versus the straight one is because of the prostate. Sometimes prostates are so large, it's hard to get around them. And this kind of shows what that looks like. So I always say that, the guy who invented the Lakeshore Drive for Chicago was an idiot, because he put this S-turn on the drive. Now, I don't know if they did it because they wanted cars to go slower, but anyone who's ever driven now they've actually taken the S curve and straightened it out more. But anyone who ever in the old days took that S curve, it was terrible. Well, the guy who created men wasn't much better, because he put this crazy S curve over here in the, on the male side too. So the one curve is easy enough to get rid of. You just pull the penis straight, you get rid of that one curve. But the other one, the prostate, can be significant. And sometimes a coude will make a huge difference in a soft, and some will come in a hard form. So it's, again, a choice. Why would I pick a soft catheter versus a hard catheter? Well, it depends on whether you need that flexibility sometimes, or do you need that stiffness? Sometimes the stiffness will make it go in better. So at this point, I think I'm going to my full screen here, and I'll get some samples going here for you. So these are a couple of catheters. As you can see, this one here is the straight cath, and then this one is the coude. Now, most of these coudes have a marking on the back here that shows what up is. So you always want to insert it with it going up. This one happens to have a blue line. I'm not sure how well that's showing up again, my shirt or against me. But anyway, it has a blue line. So you can tell them when they're inserting it, make sure that you start with it going up, but then that you continue to see that blue line the whole time. So as you're inserting it, you can see that the catheter is going in with the blue line up. Or they can try to feel for this little groove. These are soft. Again, my favorite catheter, the one I would always go to first, straight, soft. And just because I've had the most success with it. Now, the reason I wouldn't say go to a coude on every man because they've got a prostate is you don't always need it. Number one. Number two, sometimes they get confused and they put the catheter coude in upside down. And an upside down coude is worse than a flat, straight catheter when you're trying to insert that. So my tip is to start off with this. I always work with the patient personally, and I'm going to go through some techniques of how I have them insert the catheter. So we'll go through that. But I think that starting with a straight catheter, a soft catheter works out best. Now, sometimes the stiffer ones can be easier to push for some of the guys that don't have as much strength. These floppy ones being soft, they do bend. So sometimes that can be an issue. And you get a patient and he's getting one of these, that could be the problem. Now, the other thing is and I've got a bunch of these here, are all these pre-lubricated catheters. So we've got Lofrix, and we have this one's Hollister's Vapro, and this is the Speedy Cath. All have different methods for lubricating them. I'm not going to pop these bags and make a mess all over myself, but this one has a pop bag. You pop it and it releases their urotonic fluid so that it's at the same pH or same sodium as the body, so that it doesn't draw water in or out of the urethra. That's their big claim to fame, and they patented it, so it must be something there. But it's kind of a stiffer. It's a little bit stiffer of a catheter. I almost put this at like a medium stiffness. It's not as stiff as some of the other ones, and the one I'm going to bring up here is the Speedy Cath. Now, this one's already pre-lubricated. You don't have anything to pop. You just simply open it and go. Now, this one is pretty stiff, and maybe I will open this one just to kind of show the difference between a stiff one and one that's not quite so stiff. So this one, when you're pushing, it's pretty tough to get it to kink. Now, super slippery. I mean, the beauty of these is slippery. The bad thing is it's slippery. One of the nice things about a non-lubricated catheter is you can lubricate half of it. And then you've got this part not lubricated to grip onto. Some of them do come with grippers to help push that. And I'm going to show you something like that here in a second. But even with the pusher, sometimes it doesn't do the job. Now, since I was giving the talk, I always look at my cabinet all fun to see what new stuff is in there, because I don't always see all the reps. There was this new one that came out. It's called the Feel Clean Air. And it's a little satchel. It's got a bag you break, releases a fluid that then lubricates the catheter. And I'm going to show you what the pusher looks like. So this is I'll put this somewhere I don't get all wet. So this is what it looks like. It's rolled around, plus or minus on the rolling, because you can see that roll stays in it. I'm not 100% sure I like that, but they didn't ask me. So this is the pusher that they have. And, it does give you some grip, probably over trying to push on just a lubricated part of the catheter. So I like that. And again, you can advance that all the way through. Now, their neat invention, if you have to call it an invention, is the bag. So this is on the go. A lot of our population is very active, and they're getting around. When you're done, you can put it right back inside the bag it came in, seal it, and throw it away. So you've got a nice, simple. And plus, the other thing is, if you're carrying this, I didn't know it was a catheter bag. I knew it was a catheter because it was in my catheter closet. But otherwise, I had no idea what it was. So I think that's the nice thing, is people want something that's concealable. Would fit. I guess I do have a shirt pocket. It would fit in a shirt pocket, and it doesn't even block the Uro nurse. So I like that. There was another. Oh, and I did have before that one. I ripped open ahead of time so I could play with it. But they do make it easy if you have disabilities for trying to open them. They do have it so it's easy to open. And then my last catheter sample I'm going to share with you, I have not opened yet. It's Speedy Cath, because I'm curious what it's like. The Flex Coude Pro. Sounds good, right? So it has a peel back here. Again, does not look like a catheter. Looks like it's a bag I could probably put the catheter back in to get rid of. Wow, why you shouldn't do this on live TV. So that came off and nothing happened. Maybe something was supposed to open. I don't know. Oh, wait a second.
Can you bring it up a little bit and show us?
There it is. So I waited so I could do this live. So I should have practiced, right? So it doesn't open up here. So don't even take the tag off. I was waiting for a big surprise. But it's the nice thing is it's not, I'm going to do that. It doesn't drip all over you. So, and it's all self-contained with a bag, which is kind of neat around it. Now, the things I'll do for UroNurse. It does come apart like this. So, oh, that's pretty neat. So that, so it does.
Did you have to twist that to unlock it?
It does have a screw tip. So it's screwed together like that. And you open it here, and I will warn you, I have a towel on my lap because I don't want to make a mess, but it did drip a little bit, but not a lot. Now this thing here can be used as a holder. It's got the coude tip, and you can really get pretty good grip on it to push it. I like it. It's slippery, and it kind of collapses the bag as you go. Hopefully that was the only thing I don't really see is how you can mark to tell that your coude is going up. So that's the only thing I don't really see on it, but it does have a little marking over here. It's not real easy. I don't know if it shows up on the screen too well, but it does have a little mark. So there is a marking to show you. Kind of neat. So this is one I had just seen. I haven't seen the prior. I had heard they were coming up with one. It's definitely soft, so it wins that on my choices. All self-contained. And I'm guessing it will fit back into that bag nicely, which it does.
I think the tab that you removed may be used to secure that bag, like say on the wall of a bathroom stall, so that it keeps both hands free.
It is really sticky. So I think you're
Okay.
right. So if you wanted to have the bag adhered. So yeah.
So it's interesting that they're very considerate to create that. But for someone, a user who has manual dexterity problems, that twisting to unlock the catheter may be problematic.
Yeah. I mean, the bag was easy enough to open once I figured it out. It does have an arrow. It's hard probably to see on TV that shows. I'm dating myself. I'm calling it television, right? Probably on the stream it's hard to see, but it does have a twist. I mean, I have pretty good dexterity, so I'm not so sure. But again, as I said earlier, you always want to match the catheter with the patient. So this is not something I would give somebody with limited dexterity. So good point. But I tell you, somebody with a bit of an obstructing prostate, this is a beautiful thing. So, and that's the nice thing is all these companies have come up with different new innovations, and they're constantly innovating. Bring them back up here to my screen. So that was my little show and tell. Now that I'm all sticky from that stuff. Oops, I keep hitting the wrong button. The other thing I want to mention is we always want to let patients know that all catheters are now labeled as single use only, as required by the FDA. Years ago when I started, catheters weren't paid for. So patients were reusing them, and we had techniques that we could, have patients reuse their catheters. And, I think I will tell you some stories. Patients have told me that they had used the same catheter for a year with the techniques that I taught them. Now, I had learned about soaking them in vinegar water. I wasn't a big fan of that, but I read about this study where they actually would microwave it. And the thought is, the way microwaves work is they boil water. They cause water molecules to vibrate, and they convert from water to steam eventually. And that would lyse open a bacteria, which has fluid in its inside, in its cytoplasm. So I thought, well, that was worth a try. I actually did some experiments myself where I took and inoculated some catheters with contaminant, and then put it in the microwave, zapped it, you had to put a glass of water because it's not enough to absorb. It would hurt your microwave. Put a glass of water in, zap the tube for a minute, throw your water out. And then I took it. I had a microbiology lab at where I work. So I went and I sent it off for culture and it came back negative. So, it was positive before and negative after I microwaved it. So they did work, but again, not suggesting it. It's single use, but I thought it's worth sharing. The other thing is you want to have teaching for the patients. Send them home with something. Don't just tell them and then expect them to remember, because most of us, our memories aren't that great as we get older. And even the younger ones, you need to have something there for them to kind of look back at. Suna has a great sheet on intermittent catheterization. It really goes into a long introduction, how to perform it, materials needed. It's really well written. There's a lot of information here. It's 3 pages of information. Now, I just put together a new patio set for my patio. I have a little place that we wanted to sit out and look at the lake and have breakfast. So it's one of these high tables and 2 tall chairs. And it's made of this polywood stuff. That's that special wood thing that's kind of a plasticky wood, composite, they call it. Anyway, I got the instructions that had to be put together. There was not one word in that instruction. Everything was a picture. And if you ever went to like IKEA and these things that you assemble your own furniture, they don't put words anymore. I think that they're smart. There's people smarter than us that have come up with these ideas. And my proposals, I think we should be doing the same thing when we teach intermittent catheterization. Get rid of the words. I mean, I know Suna put a lot of work and effort into it, but the last page is the one that I was using, the pictures. And I think that you could come up with something similar to this, where it tells you exactly what to do. Wash your hands first. How a man should be putting a catheter. Most of the guys I taught like to just use it right over the toilet, so it's very normal. And then a picture to show that it's a throwaway, one-time use. So just like IKEA, I think that pictures are going to do much better. And the same thing for when I give women instructions. I found this one years ago. Now, this came from a talk I gave a long time ago, and I don't even know where this picture came from, so I can't credit whoever came up with it, but I love it. It just shows different techniques for women to catheterize. And a lot of times, females, guys got it made because it's a little easy, pretty easy to find the urethra. And for a man, once you find a urethra, the big problem is getting through your prostate. For a woman, it's finding the urethra, then it's home free once you find it. So, these are different ways that they can make it easier to catheterize. And I thought this is a great picture for that. Again, pictures are going to be a lot better than words. When I'm teaching females to catheterize, the technique I found that works the best is I put them up on our table, and it can be positioned so that it's almost like sitting on the toilet, but at least I can get down where I can see. And I have them hold the catheter, and then I kind of guide their hand so that it touches the urethra. The tip of it actually touches the urethra. And when they feel that sensation, they kind of recognize what the urethra feels like compared to everything else down in their anatomy. And sometimes if they're having a lot of trouble, I even tell them they could, place a finger in the vagina and just go above that, and that'll work. But I think the biggest thing is once they feel that area, and then I have them do a return demonstration without my hand helping them, and they've got that sensation, a couple pokes, and they're finding it just perfectly, no problems. Also, I think that Google can be a good place to go for, sending them to get some information. However, I would look at these different videos myself first, and if I like it, then I would recommend it. I wouldn't just tell them, hey, just look it up on Google, because you might be teaching them things that aren't really good. Again, pictures. I like, this is another one I found recently, just some more pictures on how to catheterize. I'm not a big fan of the mirror. I know people have taught with females with mirrors, and they probably can go back and forth to whether they like it or not. When you work with a mirror, up is down, down is up, and it's kind of not a one for one. So sometimes it gets confusing, but if it works, whatever works, that's all I think that matters. I always have an iPad with me because that's what I use for my EMR. And I keep some of these anatomical pictures there. And I like this one especially because it's one of the things I hear from a lot of patients is the fact that they say, hey, how far do I go in? They're afraid they're going to rupture something or, go right through their bladder. And when you show them an anatomical picture of how long the urethra is, they get an idea. And you kind of show them that even if you push it all the way, it's just going to get into the bladder. It's not going to go through your bladder. So this is, to me, a reassuring picture to show them. And now I'm going to show you my technique here for how to insert a catheter. And I like this, is what I tell them is to grab and push to the penis. Grab and push to the penis. Grab and push to the penis. And I found that that technique has been highly successful for me for patients learning how to catheterize themselves. And you're only working with about 1 inch at a time, so it's less apt to buckle. So I really like that method. And it's really, that's all I have to say about it. I highly recommend that you encourage self-catheterization. It's a much better lifestyle. I have rarely had a patient come back and say, hey, I'd really like to have that catheter put back in. So any questions or comments out there, feel free to put those in the comment box. Lori, feel free to put any of the questions that came up on the screen. We'll be glad to answer any of those or any thoughts that you might have. And panelists, I'll turn it over to you.
I have a comment. And when I teach somebody and they're really scared, I tell them basically every time I've taught somebody how to do this, everybody will convert to it. I mean, it's very rare that I have somebody that doesn't. Like, it's very simple. The one thing I do is that I will teach them with the simplest catheter, because when you show them those packages, the sleeves, the curled up, and they get scared. They're just like, I don't know, so I straight up start with a straight catheter, easy, not necessarily the lubricant plus the catheter, but it is pre-lubricated, but something that doesn't have sleeves and all this other stuff, because that kind of overwhelms them. And then I start with that, and then I'll have them call me in a week and we'll go over what works for them. What do you think is your barrier, or if there are any, and then we kind of tweak it that way and maybe introduce some of those more, complicated catheters.
Yeah, I think that's a good point.
Susie Swain said, I like the picture idea for the CIC training for sure. I do too. I recently got something that I had to put together, and I noticed there's no words, but it was very easy to put it together. It was pretty neat.
I think it's actually easier without having the words to kind of read through. Maybe it's just me, but I just find pictures, what do they say? A picture's worth 1,000 words. So I don't like to read 1,000 words. I'm lazy.
Yeah. We also have, a lot of these catheter reps have video books that they're rechargeable, whatever. And I will give those to patients before I even come in the room. I let them watch it first and then come in, and it just kind of starts it off. So you're not starting from square one when you go in there. So they have some kind of idea before you actually do it.
Yeah, I think that's really a good idea. As long as you've got the person there too, because I think that you need a coach. No matter what you're involved in, coaching is always going to make it better. If you're a swimmer, your swim coach is going to tell you, hey, I don't like that style. You're doing this wrong. Try this. I had a son as a personal trainer, or started off as a personal trainer, and that's what he did. He coached people on how to properly lift, proper body mechanics, etc. Coaching is no difference for intermittent catheter. You need a good coach to tell you how you should be doing that. And I think it was a good demonstration to your point about not giving them too many confusing things. Look at me. Yeah. I do this all the time for a living. I had trouble figuring out how to get in
Yeah, I agree with that bag, the catheters in that bag, the Bago catheters, because that overwhelms them completely. I don't bother with that. No way. I ask our catheter reps to give us, a bunch of one kind, different kinds, but multiple, so that they can start with the same thing and then tweak it from there.
Yeah.
So Susie Swain said, I like that you open the new CIC catheter on air because it shows how difficult some of the packaging is to work with. Yep, for sure.
Yeah. Well, and I had, some method to my madness. I thought, let's start from scratch. This was one I never saw before, and I thought it'd be, I didn't think I was going to have quite as much, trouble, but in some ways, I think it showed more by my struggling with it than had it been perfect. So, yeah. And it's another reason why you need to get coaching, because you don't want the patient to go home with this device and they can't open it. It doesn't do them any good.
I think it's very helpful, and I think people have to realize that you can have somebody else do it to you. So if they want to bring their spouse or whatever, sometimes it's better that somebody else listens to it as well. Because even though they may not have the dexterity to do it, if their loved one or whoever is comfortable doing it for them, they can do that too.
Yeah, absolutely. Oh, those are
Like
all.
you already mentioned, Vic, I think education is extremely important. Humans generally have we want to do two things. Number one, we want to survive. And number two, we want to do it in the simplest way possible. And as you already mentioned, we're lazy. So you want to present whatever information you want your patient to learn in the way that they can learn the easiest. I'm very, very visual. I like pictures. Having put together something with one of my daughters recently from IKEA, it's all pictures. And it saves the manufacturers having to translate the instructions into multiple languages if they can portray it in photos. So you want to pick the medium that resonates most with your patient. If they're a video person, you have that available. If you're a picture person, you have that too, or in writing. You want to present it in a way that they can absorb that the best. Shared decision making, like you mentioned, Vic. You want to work with your patient and do what works best for that patient. Dexterity issues, obese female with a lot of redundant vulvar tissue, recessed urethra, atrophic vaginal area, genital urinary symptoms of menopause. So those are all considerations. Mirrors. They actually make mirrors for females that strap to the legs, and they make a right-handed and a left-handed mirror. It's interesting how that works. I'm waiting for one that has a ring light built into that mirror that is USB rechargeable that they can strap to the legs. Now that will be a sales idea for some ladies who need to do CIC.
Yep.
As far as the stiffness of the catheters, there's the softer that you like or the stiffer kind, which may be needed for, say, an enlarged prostate, or the catheter that is being used to dilate a urethral stricture, which we haven't talked about. So picking the right weapon for what you need to do is important. And I think I'm just going to, a couple of more points. And one of them is to avoid, for men, to avoid needing a catheter, to avoid that neurogenic bladder for most men is not a neurologic event, but treating that enlarged prostate sooner than later. I talk to my patients all the time. You want to get this treated sooner than later so your bladder will continue to work. I don't really care too much about the prostate. I worry about your bladder.
Yeah.
Once it quits working, are you willing to put a catheter in your bladder through the penis 6 or 7 times a day? Or wear a catheter all the time through the urethra or a suprapubic area? So when you paint that picture to the patient, they're more likely to take action on something that is really important to them. And lastly, there is a Facebook group called Intermittent Catheterization Facebook group. If you really want to be empathetic to the users, go on that Facebook group and read all the struggles that all the patients have. Yeah. It could be something as simple as running out of catheters while on vacation, learning how to reuse a catheter that they have, but they forgot to bring on their vacation. So many issues that we never even thought of that are extremely germane to the end user, the patient, him or herself. Back to you, Vic.
Those are some good points.
So we have a question from Janelle Finn. We are considering a CUDA catheter for a female patient that has severe atrophy, difficult cath. What do you think?
Yeah, I think that kind of falls into what John was talking about, dilation. So, with the CUDA, it is narrower tip. So it is kind of almost like a dilator. And sometimes that could be, if you ever use the female dilators, that's how they're built. They're thin and they get fatter as they go through. So I think that, Janelle, that would be a good idea if you're doing that. We had early on in my career, we had a number of patients that were coming in with urethral strictures, and they tend to recur. I'm sure John's got a bunch in his practice. And the routine was they came in, they got sounded and popped open the stricture. They did fine for some period of time, and then they'd come back. And I said to one of the urologists, I says, wouldn't it help if these guys like catheterized periodically and just kept that thing popped open? And he said, well, there's been some stuff that they've looked at in doing that. I says, well, let me come up with a routine. So I did. I came up with a protocol for doing intermittent catheterization for strictures, and started with a smaller catheter and then built it up to, I think it was an 18 with intermittent catheters. And it was catheterizing every day, once a day. And then it kept reducing how often you're doing it to every other day. Eventually it was down to once a week. If you started encountering issues where it was hard to put it in, you went back up the other way. Well, I can tell you that I, throughout my career, had a number of patients that were coming in on a regular basis for urethral dilation that no longer come in for dilation. Some of these scar open, perfect. Some of these are just controlled by periodic self-catheterization. So, as you said, there's a lot of things that can be done with proper assessment.
Speaking of self-dilation, go ahead.
I actually had a patient who had, a stricture. It was a female, and she would actually come to the office once a week, and I would put in an 18 or 20 and leave it there for 5-10 minutes, just once a week. And it kept her from having a formal dilation. And she was so happy with it.
Yeah. Go ahead, John.
Oh, speaking of self-dilation, believe it or not, there are sounds, urethral sounds, that anyone can purchase on Amazon and on eBay. Mind blown, right? So people use these sounds not purely for medical purposes. That's
yes.
Let's just leave it there.
Yeah. I remember the reason I got the idea for the intermittent catheterization is, and I've been around long enough, is there was a catheter that we had. I can't remember the name of it, but it was a balloon catheter. And basically you did that. You put the intermittent cath in, you fill the balloon, it would dilate and would fix the stricture. Well, the company that made them either went out of business or quit making them or something. And that's when I switched over to this routine with the self-cath. I'm telling you that we never went back. That was our go-to. We still have that protocol in place.
Well, I have a suggestion for you. So in general, you have that direct vision internal urethrotomy or manual dilation. You have open urethroplasty. Now, what you just mentioned, that balloon dilation, there's something called UroLube that is available. Not only does it dilate the urethra, it also delivers a medicine to minimize the risk of recurrence. You may want to reach out to them and see if they're willing to come on UroNurse to teach everyone.
Guess what? They're coming on. They're in the pipeline, I think 2 weeks, I believe.
Excellent.
Yeah. So it's interesting to see all the new innovative inventions that have come out. Innovative invention, that's kind of redundant, but all the things that come out in urology. I mean, when I started UroNurse, I never thought there'd be so much stuff out there, new products that could be, looked at, because we see the tip of the iceberg in our offices. It's the companies with big money that are able to have a huge sales force that come in, and these are the ones that you get introduced to. But UroNurse has been able to capture the smaller companies that don't have the big dollars to spend, and they're finding out about us and saying, hey, I'd like to, be able to talk about our product. And these small companies are getting, some advertisement for them, which is great for them, but even better for us, exposure. I mean, these are things that I think are important that patients have as an access. I can tell you, if somebody's going to wear a leg bag and I can't talk them out of it, I'm sending them to Cathwear to get one of those pairs of underwear to hold it, because that's always a big problem.
Yeah, definitely. Yeah, there's a lot of innovation in urology. There's always been a lot of innovation in urology. You just simply need to attend an American Urologic Association's annual meeting. Go to the exhibitors area. It's insane the number of new products that are being pitched to the end user.
Yeah.
Private equity interest in urology, right? Somebody interested in making money is buying a lot of these urology practices. The largest, I believe, is Solaris. They have over 600 urologists under their umbrella. So there's a lot of money to be made in urology. That's why there's a lot of innovation, and I think that's why there's private equity interest. over the last several years.
That's a good point. Well, Lori, do we have any other questions coming in from the audience?
I don't see any other questions at the moment.
All right. Well, I think that we've done a great job here at covering today's topic. So I'm good if there's no other questions. Audience, always a pleasure to have you on board. I see we've got quite a few that showed up for the show again. We're always glad to have you here. So at this point, I will put a plug in for next week's episode. We're going to stick with the skills. I think this is really important. It's reprocessing medical equipment. I'm not talking about the disposables. I'm talking about the stuff that we use day in and day out over and over again. And how do you reprocess this so that, we're not getting patients infected? And it's changed quite a bit. And I've got some good stories of some of my research that I did for the AUA and SUNA for the reprocessing of prostate biopsy equipment. And some of it will make you pretty scared when you see what was being done in the past. So anyway,
I'm reminded of a lawsuit in Vegas of a urologist in that regard. Yeah. And that topic, the reprocessing, is going to be extremely germane.
Yeah.
Reprocessing for urethral catheters. I just read on the Intermittent Catheterization Facebook group that somebody's actually traveling somewhere. They only have one catheter that they had. If they had instructions on how to reprocess that while they're remote, that might be a good idea. But anyway, not typically. Normally, single-use catheter, use it once, throw it away.
Yep. Hey, thanks for the comment there, April. Janelle, thank you too. Elizabeth, thank you. So yes, I think it's going to be interesting, and again, if you guys have any thoughts for different episodes, feel free to put those in on our website at any time. Submit. That's where I get some of my ideas. Some of my best ideas come from you guys. So with that, I'm going to let everybody off. I've got a little family party coming up here, so I got to get ready for that too. So enjoy the rest of your summer, and we'll see you all next week.
Bye.
Thank you, everyone. Bye-bye.